Okay, I will introduce our panel and then we will introduce a short video that will set the stage and then we will get going. So let me start off by introducing our esteemed panel. We have joining us today a colleague from, two colleagues from Amref actually, Caroline Mbindyo. Caroline is the CEO of Amref Health Innovations based at our HQ in Nairobi. Good evening, Caroline. Thanks for being here. And we also have Dr. Catherine Kanari, who is working on the Universal Health as the Universal Health Coverage Lead, also working under Amref Health Innovations in Nairobi. So they'll be offering some expert opinions and firsthand knowledge and information on some of our innovations. Thank you both so much for being here. But we will start with a short video, so a few seconds clip that will sort of set the stage and give you a visual of some of what our innovations are looking like now through a solar-powered mobile clinic. And then we'll get started. So take it away with the video. Thank you.
But this can take health services, unskilled health workers, closer to the people in a safe manner. And the fact that it is solar powered means it doesn't have to depend on grid electricity. It can actually provide its own energy and therefore reach the last mile and the last meter to provide primary healthcare services. The future of healthcare in Africa is getting health services closest to the people. The mobile unit is just one of those tools to actually achieve that.
Thanks very much. Thank you. Okay, well, warm welcome again to both Caroline and to Catherine. I think we will get ready to get started. So I will start with you, Caroline, if that's all right. Are you able to share with us some additional information on how mobile clinics, mobile vaccine clinics are impacting our work, particularly in areas that are low resourced?
Yeah, thank you, Ky'okusinga. Hi, everyone. I'm very happy to be here with you today. And thanks for that question. If COVID taught us anything, it's that all of us are vulnerable. It's that health drives the world, and that where you live still determines your access to health services. So today, we are almost 2 years after the first COVID vaccine received approval in 2020, December 2020. Today, 64% of the global population is fully vaccinated against COVID. But if you drill down into those numbers, you'll find 83% fully vaccinated in Canada, 76% in the UK, 69% in the US, and in Africa, only 24%. 24%. Africa was at the back of the COVID vaccine queue. We were the last continent to receive vaccines, and this difficult access to these doses of vaccination, it really affected and undermined the efforts towards vaccination because, at that time, that is when the incentives to get vaccinated were highest. So we are now trying when the incentives are lower, when people have, most people feel, but the pandemic is over. Why do I need to get a vaccination? So earlier this year, Amref, with other partners, did a study to help us to understand how to drive and how to accelerate the uptake of the COVID vaccine. It was very clear that access plays a key role. And when we say access, it includes factors like supply chain, trained health workers, and of course, the convenience of the location. And convenience remains a critical driver of vaccination uptake, particularly when this low risk perception of the pandemic is there. And the idea around making vaccinations convenient bringing the vaccine to the people, as opposed to asking people to come to where the vaccination is the thinking behind this mobile vaccination units, or MVCs as we call them. So the MVCs so far have been used to increase access to vaccinations for elderly who cannot travel out of their homes to get this vaccine. For people who want to access the vaccine after hours. So the clinic is open late into the night. We open until 9 o'clock every day, so that people, as they're coming out of their offices and they're walking home and their workplaces, and most of these are informal sector workers, it's provided access to people who are in the market as they're doing their business. When they have an opportune moment, they can come to the mobile vaccine and get the vaccination. We bring it to young people where they are, in universities, in places where they gather. We bring it to people with disabilities. So we are actually going to where the people need the services the most and providing that services. And although we built the MVCs to support vaccination uptake, the idea is that these MVCs can and should be a resource that are used for any last mile access use case. So it could be access to other vaccines. We've already seen HPV vaccine being deployed using this same mobile vaccination units. It could be the routine vaccination for children. We could use it to enable screening, early diagnosis. In a country like Kenya, for example, children who have leukemia, they have a survivability rate of 20%. In the US, it is upwards of 90%. And the reason for this is late diagnosis and lack of access to services. So if we can bring diagnosis through these mobile vaccination clinics right to the communities where the people are, we can be able to shift some of these numbers. And of course, we have the sustainability question that we are working on right now, that even after this COVID campaign is over, how do we continue to use these mobile vaccination units to provide services to communities where they are and the service that they need?
Thank you, Caroline. I mean, I think, the idea of convenience, of getting, giving access to people where they're at makes sense to everybody on this call, right? And it sounds like innovation on top of innovation, really, because when you think we're already there, we're already administering COVID vaccines. While we're at it, what about childhood vaccines or any other sort of primary care needs that the community needs? Mm-hmm. That's fantastic. Thank you. So much to unpack there, but we will move on to the second question and have discussions later. And Catherine, this one is for you. If you can share with us one of your favorite success stories around an innovation that has been implemented by Amref, what would that be?
Thanks, Ky'okusinga. Thanks for the question. Happy to be here. And so I'll just pick on from what Caroline has just finished speaking about. And so for me, I think one of my biggest or best success stories lies around a program that we do called Blueprint, that looks at the patient journey and the patient journey gaps and tries to address these challenges in an end-to-end manner. And this work has then enabled us to co-create a solution with several organizations. So looking at how you partner well with people who can do what they do the best, and then leading to impact that looks at then reducing cases of NCDs. When we look at the universal health coverage agenda, we see that one of the key things is affordability of healthcare, but also access to quality healthcare. And so one of the key gaps that we have in Africa as a whole is in the non-communicable disease space, and chronic care diseases, where it costs a lot to then look for treatments and to then seek that care. And so within this implementation, we then sought to co-create a solution with other organizations that then tackles that bits and pieces of the patient journeys that they struggle with. And so this has seen us then equip the health system or strengthen the health systems, looking at the community health systems where Amref really plays well, training community health volunteers, looking at the prevalent disease areas, which were hypertension, diabetes, and cancer. And so equipping them, capacity building them to raise awareness in the communities, to do some sort of screening and referrals to facilities. And then when the patient then gets to the facility, we need then a ready system where we have primary healthcare workers that needs to be built their capacity. And so we followed the continuum, and so far we've seen so many achievements. Mainly what I want to laud is the reduction in finding cancer cases at stage 3 and 4. We can now happily say that, and which is very rare in Africa, that we are finding stage 1 and 2, they're being diagnosed in good time. And then we are also working on the supply chain end where they're able to then access their care. We've also advocated for increased formulary within our essential medicines. So generally then preparing the supply side of things. If you raise the demand, you're doing the prevention mechanisms, you're doing the screening, then you need to prepare for the treatment and how the patients pay for the treatment, inclusive of palliative care, and overlaying all this is data. So I'd say we've done a lot of work around that, and we've seen so many good results. In a county where we did not have many cancer cases, we are now seeing at least upwards of 500 cancer cases on treatment, and not necessarily on the mortality trend. So this, for me, speaks to how you do things in partnerships, innovatively looking at the patient journey and co-creating that with them, and also layering technology, because during COVID, our work had to continue. So training on mHealth platforms and collecting that data so that it informs decision-making and changes in policy. So we can delve later, but I know I'm eating on time. So just a touch of that. Thank you.
No, that's great. That's great, Catherine. And I mean, there's so many takeaways, but I think, you know, something important that we hear from what you're telling us is we don't have to reinvent the wheel all the time, right? You leverage, you partner, you collaborate, you take what you already have and make it work for you. And it sounds like from what you described, yeah, it's working really well. Thank you. Okay, and back to you, Caroline. You know, talk to us a little bit about what excites you about our work around around innovation. You know, what excites you about this? And maybe as a secondary question, if we have time to get to it, have you yourself been working with at the community level when creating these innovative solutions? So 2 questions, but I can read the second one if you need me to.
Okay, that's a really good question. On my desk in my office, there's a saying that, you know, hangs there, and it says, when health is absent, wisdom cannot reveal itself. Art cannot manifest, strength cannot fight, wealth becomes useless, and intelligence cannot be applied. And when you listen to what Catherine said, it's not about innovation for innovation's sake. It's about innovation for solving problems. And at Amref, we believe that the solutions to Africa's problems will come from Africa. We know that talent is everywhere, but opportunity is not. If you look at, you know, the Africa that we live in, most of the people know, you know, the dire statistics, the highest mortality rates of the poorest, you know, communities. Those statistics are well known, but less known is that today, you know, Africa, our median age is 19.3. We have over 1 billion unique mobile subscribers. 47% of the continent currently has access to electricity. We have a very rapid urbanization rate, more rapid than India, I think equal to China. If you look at last year, 2021, we had 7 tech-driven unicorns in the continent. Our population currently stands at 1.3 billion. That is a large market. And by 2050, it is projected that 1 in every 4 people in the world will be living in Africa, will be an African. So when I see that, I see, of course, challenges, but I also see opportunity. And Africa is rising, and together with our partners, with Amref's partners, we want to be at the forefront of making health present, because if health is present, all these other things that we have spoken about can happen. And looking at the communities themselves, that is where real innovation can come from. That is where we can solve problems, not by ourselves, but with the communities who have lived experience, who understand their own context, and who can advise on how do we build solutions. So if I look at, Amref says communities are at the heart of what we do. They are at the heart. So we cannot do anything without communities. If you look at a product like Leap that Catherine was talking about, Leap is a mobile learning platform that we use to train health workers from across the continent. And when we were developing Leap, I would say it's almost 10 years old now. And it has gone through various iterations. When we were developing the first iteration, communities were key partners as we did that. And they helped us to understand that, first of all, mobile was the way to go. They helped us to understand which mobile device should we be designing this problem for. What language should we use? How long should a topic last? What features should we include to ensure that there's collaboration and that they can be able to access the content? What incentives work for them? How should supervision look like, etc.? And without this very critical feedback, Leap would not be where it is today. Used across 8 countries, adapted by ministries of health, trained hundreds of thousands of community health workers, and reached millions of households with very critical health information and collecting health data that helps us to understand how to ensure that the interventions, the programs that we are designing are taking into consideration these communities who need these interventions.
Wow, Caroline, that was fantastic. Made me want to throw my arms up and say yes. And I think I can probably speak on behalf of all of the Amref colleagues that are here today to say, I think this is why we all get out of bed and do the work that we do. And this is what excites all of us, around this work. Thank you. Fantastic. Catherine, I will jump over to you and building, I guess, on what Caroline has talked to us about. It really is inspirational and it's exciting, and this is the time. This is Africa's time. This is our time to make all the changes and build all the systems that we need to build. But of course, as we do that, to do it in a sustainable, we need to think about in a sustainable way. We need to think about what barriers and how we work around them, because of course there'll always be barriers to get to where we want to be. So in your view, Catherine, with your experience, can you talk to us about some of the barriers to innovation that we are facing or that we could be facing in the very near future?
Thanks, Ky'okusinga. Interesting question. I was just pausing to remember that one of my key things is to look at the way we implement is the learning, unlearning, and relearning. And this has then forced us to look at innovation differently. You can have innovation in terms of technology, you can have innovations in terms of how you deliver, but you can also have innovations around social areas like inclusivity. So I'll want to answer this question a bit differently than is customary. And I'll say some of the work we are doing is actually visionary. We look at challenges in various angles, but we also have to realize that as humanity, we have general challenges that affect all of us. And this includes things like disability. So for example, as Caroline was mentioning LEAP, we now are trying to then train visually impaired community health workers, which is something that has not been tried in Africa. And when we started this piece of work, we then had to interact in this space of inclusivity. And we found that majority of the people or the people we are trying to train have stories behind how they became impaired. And we always look at anyone with disabilities as being unable to then contribute to the healthcare workforce, contribute to meaningful work within the society, especially around health. And one of the ladies that we had gave as a story, she was a teacher and she became blind because she had a tumor. And so when we presented this opportunity, she was in herself challenged that, you mean I can still be a productive person in society despite my disability? And so when we look at that, we see that when we look at the challenges, they are all humane. And so she was among the first cohort to then be trained for this work. They are being trained using our LEAP platform, which we've enabled to then include that visual impairment. But also then they will be able to carry out cancer screenings for breast cancer because their tactile sense is more perceptive than normal people, normally visual people. And so these are the things that when we look at challenges, you start at the personal level and societal level, and then you move on to the systemic challenges that we know exist world over. So challenges to do with change and change management, challenges to do with accepting the innovations and accepting the basics of that the world is changing, and governments then recognizing that we may need to do things a bit differently and with speed if at all we are going to cover the health needs and achieve this universal health coverage. So those are my thoughts around that. Thank you.
And Ky'okusinga, if I can just add on to what Catherine said, if we think back to COVID and just what COVID showed us that we are able to do, I think in much of Africa, you would never have had the opportunity to say we can have meetings, government meetings where we are agreeing on things online. It had to be face to face, and we knew that that is how things work. But that, I mean, overnight that changed. We talked about, having online school, and we said, that is in the next 5 to 10 years in Africa. But overnight, literally overnight, we were saying, there's no more school. We have to figure out how to do school online. So that mind shift, I think, is so critical. Saying that instead of saying we cannot, or maybe in the future we will, being able to say, why not? Why don't we try it? I think that is so critical. But I think also another big barrier is, is the regulatory environment. If you look at Africa, I talked about the market size, 1.3 billion people, but we are also 50 plus countries in Africa with, 50 different regulations, standards, guidelines. And, when you look at innovation and introducing something in one country and asking yourself, how will it work in Rwanda? How will it work in Ghana? How do I build an innovation that can universally work across these different geographies? I think that is definitely a barrier that if we do not address, it will limit how well we can be able to innovate across the continent.
Yes, thank you both. Those are excellent points. And I think, part of it, part of what you outlined, Catherine, is just the human barriers probably that are faced around the world when you're in a certain situation and you can't see yourself in another situation. You can't see yourself as being able to work as any other able-bodied person or understanding change. But I do think, and absolutely what you said, Caroline, about what we've learned in this moment, and it feels to me like we almost have to harness this moment because we're still in it, where we're still open to different ways of doing things and embracing that. It feels like this is the time to really make those changes, to plant the seeds for massive growth and massive change in the future. And yes, I know there's tons of conversations about different sort of regions and regulatory bodies that work across regions, whether it's the East Africa region or Southern Africa. But yeah, there's nothing like bureaucracy to completely hamper innovation and stall it in its feet. So yeah, good points there. All right. Next question, I guess. You know what, I'll throw it to the both of you. Whoever, I hope that we can hear from both of you on it because it'll be interesting to hear, but whoever wants to take it first. What do you think, when you look ahead a little bit, what do you see as the biggest category of innovation that we will be focusing on in the future? It sounds like a very broad question. I guess you can frame it around your own work, our work at Amref, health in Africa in general, but what is the biggest area of innovation in our future?
Do you want to go first, Catherine?
Okay, thanks. So for me, when I look at the areas that we really need to then get a lock on, I think data, and I think information that can then help us to make decisions. When we look at how we plan within Africa, sometimes the key issue has then been the numbers and knowing exactly quantification of our issues, quantification of health, and how these systems then talk to each other. Because if we were able to harness that large data, as Caroline was talking, looking at the mobile telephony and how we can then also harness that to help us collect this data, especially health and social determinants for health. And so for me, I think that's a key priority area that even taps into and leads to predictive technology, helping us know when we look at things like climate change and how it's affecting health. All this can be done very well if we have good data that then assists with that prediction and assist us to make changes accurately and aptly when they're needed. So those are just a few thoughts. Maybe Caroline can add her thoughts as well. Thank you.
Yeah,
Thank
I
you.
definitely, yeah, data is such a good one. It's such a good one and so critical. I would also say that, you know, I've spoken about the 1.3 billion population. And currently we are in the process of operationalizing a trade agreement that will create one of the largest single markets in the world. But what does this mean? For me, when I look at, you know, the social challenges that Africa is facing, I believe that their response cannot be just a public sector response, that the private sector, that it must be a whole of society response, that much as we are using, you know, the traditional NGO approaches to address these challenges, that we must also see how can we leverage market approaches to address this challenge. So when I look at this, I look at it as an opportunity to use these market approaches to drive development, to attract different types of capital to address social problems. You know, to focus on how do we solve these problems sustainably, and markets are good at solving problems sustainably. If I was to make a bet, I would bet on the youth of Africa. There are many. They are dynamic. They are full of ideas. They are hungry for success. They are already a mobile first, a digital first, you know, population. They are creating technologies in fintech, health tech, ed tech, agri-tech, pop tech, you name it. African youth are dabbling with these types of, you know, technologies. They are going to be part of the solution of addressing Africa's challenges. As Amref, we have developed various health technologies. I've mentioned, you know, the LEAP platform, and there are many others. And, you know, we want to continue to do this, to use these technologies, to collect data, to use that data, as Catherine has said, to inform practice, to inform policy, to drive change. You know, so how do we then do this? We have solutions that are looking at, for example, how can communities get access to social insurance? How can they get connected to health services? And how can this be available in the languages that they understand? I mean, Africa has over 2,000 different languages. How do we ensure that we are not leaving people out? How do we use these appropriate technologies to reach the people who we thought it is impossible to reach them? So for me, I would say youth times enterprise times technology are what is the future of Africa.
Oh, I'm still muted. Sorry, I was talking to myself. The youth in Africa are more connected and interconnected than any generation ever has been before. So before we delve into that a little deeper, Catherine, can I just come back to you and say data? You know, data is everything. We all know that. But can you give us an example of how data would fit into our work, or how data would help with the health innovations that we have planned at Amref? How would it make the work that we do, and more importantly, the work that we do for the communities that we exist to work with better? How would that improve the work?
Thanks, Ky'okusinga. So when I think data, I look at it in the practical sense, but also in the chain of which we look at how we want to do our work. I think at Amref, we are big at creating impact, and impact is a measurable thing. It's something that is tangible that you can see across board based on the interventions that you've made, and it takes a long time. So if we're able to then measure our inputs or what it is we're doing innovatively, and then also look at the outcomes and outputs, in the long run, we're going to see the impact of the same. I'll give an example maybe from the blueprint project that I was mentioning earlier. And so some of that work has enabled change of policy in the country and also at the county level. Kenya is a devolved system. So we have the national government and then we have county governments. So I'll just give three examples maybe of how data then informed policy. And so the first example is from the county itself, because they have autonomy to make choices within their health docket. They were able to then tangibly get figures of how non-communicable diseases are affecting their population. And with those tangible figures, we have been able to do advocacy from the household level, using the household and communities to then participate in the budget making process. And now they're allocating funding specifically for non-communicable diseases. Again, part of the work we do as Amref, we are huge on then utilizing community health volunteers. And so majority of these cadre of workers are not yet in a scheme of service. So they're not recognized as employees. So the thing we were then able to do is advocate for that just based on the work that they've done. And this, they had several criteria. And one of the criteria was a learning agenda using our LEAP platform. The other criteria was how well they were able to collect data from the households. Was it timely, was it accurate, and was it consistently in time? And so those are two examples at the county level. At the national level, when we were able to project the figures of, for example, breast cancer, we realized we only had 3 molecules that had been approved for use in the country under the essential medicine list. This is the list that the country then uses to procure its medication for the country. And so using the data that we're able to collect around cancer, we're able to additionally add 19 more molecules targeting specifically for cancer. And this then ensures that there's access, the country will then order, and it will be in the public system. The last bit I would add is then advocacy around how we pay for our health. As I mentioned earlier, health financing is a crucial aspect of universal health coverage. So one of the things that we were able to then push for is advocacy around the packages that are in existence in our social health insurance system. So we did not quite have chronic care packages. And so now, using those numbers again, back to the data, we are able to then advocate, and we managed to get a package that then also includes cancer care. A package that then means you pay $5 a month, and you're able to get at least 6 cycles of chemotherapy. That is big for a country where we had to pay everything out of pocket. You're also able to do some imaging around this and some diagnostics and some sort of palliative care within that package. So those are the things that I see data impacting in our work and informing decisions and change of policy for the betterment of our society. Thank you.
And Ky'okusinga, if I can add, you see, Catherine talked about the determinants of health. When we think about health, it's not just health that we need to think about. We need to think about education, we need to think about agriculture, housing, etc. So even as we work with health data, what we strive to do is overlay things like socioeconomic data over health data and try to see what can we learn from that, and what insights can we get, and how do we drive change. So if I give an example of one of the counties in Kenya, where we had both socioeconomic data and health data, which we overlaid, we used that, first of all, to identify which are the most vulnerable households so that they can be able to get a subsidy for social insurance. Then they don't get impoverished if somebody in that household becomes sick. But more than that, the county then used that same data to provide those households with an agricultural subsidy And over a period of time, over the next 2 or 3 years, we will now go back to those households and see how improving the livelihoods of those households allowed them to, be able to now afford their own health services and improved the health within those households. So looking at data, it's not just health data. It's looking at what data is available, who is it accessible to, and how can we use it to really drive change in health.
Mm-hmm. The old adage about knowledge being power, right? So you have data, which is knowledge, which is information, and that then means that people are not making decisions in the dark. And clearly an area for continued investment. Caroline, can I ask you to give us that equation you said before about marketplace plus? It sounds like the most beautiful algebra I've ever heard. If you can even remember it, it was good. You're muted though. You're muted, Caroline.
Caroline is mute. You're muted.
I'm saying I'm trying to remember. I think it's youth times enterprise times technology.
Yeah. I think equals sustainable impact and innovation. We'll make that the math equation. Wow, fantastic. There is really so much there. There's a billion questions I could ask on top of what we've already talked about, but I do want to give, we have over 40 people assembled and just about 15 minutes. So I want to give people a chance to ask questions before we go any further. So I know the chat is being monitored. I'm not sure if there are any questions, but this is a fine time to raise your hand or unmute yourself and ask a question, share a comment, share a thought. Anyone who has one? I thought I saw a hand. Yes, please go ahead, Ryan. You can just unmute yourself.
Thanks, Ky'okusinga, and thank you, Caroline and Catherine, for really outstanding discussion and quite inspiring. I'm wondering, this is not directed to anyone specifically. I invite both of you to respond, but I'm wondering to what extent you see opportunities to commercialize some of the innovations that Amref and partners are developing, and even to export the innovations beyond African borders, as I feel that many of them have application in countries outside Africa. I'd like your thoughts on that question.
Okay, so this is definitely something that we are interested in, something that we are doing. So I'll give you 2 examples. One is an innovation from an entrepreneur who is not from within Africa. And what they have done is that they have built a wearable that looks at monitoring vital signs. And what they're trying to do is provide this equipment, med tech, to facilities at level 3, which are, closer to the communities, to health facilities closer to the communities, and help them to monitor vital signs of the patients who come in effectively. So they have built their product and they want to test their product in the market. The product is currently being tested by Amref across certain health facilities within those communities and with the people who will be the ultimate user. And we are trying to test, several things. How usable, how easy to use is the device itself? How accurate is it measured against what else they have in the market? And how would it be included in the national supply chain if it was to be successful? So these are things that we are helping an entrepreneur from outside Africa to bring a product into the African market. So a market access approach. Secondly, we also run an accelerator. And so far we have accelerated over 30 different entrepreneurs, health tech, and not health tech, health entrepreneurs. Some are technology driven, others are not. And one of the entrepreneurs we accelerated has the most amazing product. It is a white cane. It's used for people who are visually impaired, and it uses technology to locate the person who's using the white cane. And it enables that person then to know what is around them using the device, the sensor that is within the white cane. And that technology, we know, will be exported and used outside of Africa before it is used in Africa, just because of the way the African infrastructure is. So absolutely, that is something that is of interest to us and something that we are working on already.
Catherine, did you have anything to add to that?
Maybe just adding to what Caroline is saying, as she mentioned, we have an accelerator, and we also have had doubled when mainly incubating businesses and preparing them for fit for market and ensuring that they can access the market. So looking at market access, but also some of the work we do is around then ensuring we can test something and scale it or co-create the scalability and then the sustainability of the same. So scaling it up once we have proven the concept. And so that looks at mainly either how we do the things we do in terms of service delivery, or looking at commodities or supplies or innovations, as Caroline was mentioning. How do we then scale this up and make a business model out of them, such that it then becomes a sustainable gesture or a sustainable venture? Thank you.
Thank you both. Ryan, does that give you some good information?
Yes, it was terrific responses. Thanks so much.
Thanks very much. Dave, did you want to jump in with something?
Hi, Ky'okusinga. Yeah, thanks everyone for being here today. A couple of comments in the chat from the little girls' school. One around a renewed effort on HIV awareness among teenage mothers, and then a supplementary comment around the need for mental health and psychosocial support. So from an innovative perspective, maybe both panelists or yourself, Ky'okusinga, you can speak to that comment. Thank you.
I will let our esteemed panelists go first if you have any answers. So I think the first one, the person said requesting we do a renewed effort on HIV awareness among teenage mothers and youth also needing mental health and psychosocial support. So I don't know. I mean, I think when we talk about HIV, certainly innovation is important because this is something we've been dealing with for decades. So I'll throw to you before I add any comments.
So I'll speak a little bit about it and then I'll hand over to Catherine. If you look at the COVID pandemic, during the COVID pandemic, a lot of schools shut down. And some of them had, I mean, in a country like Uganda, they shut down and opened this year. So there was no school for, you know, a couple of years. In Kenya, depending on where you are able to access online learning or not. But what we saw is that after the COVID pandemic was over and schools were properly, over and schools were opened, we had over, I think the figure was 250,000 girls who did not return to school. And we have declared a teenage pregnancy epidemic in the country. That so many hundreds of thousands of girls between the age of 11 and 18 are getting pregnant. So definitely the question around HIV education also comes into play here, because we are seeing that these people are having unsafe sex. So some of the things that we are doing, Amref has a huge youth platform that focuses on sexual and reproductive health. And it's not just a youth platform, it's a youth-led platform. So what they convene each other, they convene around youth events across Africa, and they speak to each other about, you know, what are their problems, what are their challenges, what are the solutions that can be driven by the youth, but what are the things that they would like from society that will help them to be able to have, meaningful lives. All the statistics, there's a lot of evidence that shows that if a person does not have at least 14 years of education, they are less likely to have, a successful career. They are more likely to remain in poverty. So how do we ensure that these girls especially get at least 14 years of education? Part of it is SRH education, especially the SRH education that will land, or not the type that we as adults who are, how many years away from teenagehood, many decades away from teenagehood, who don't understand how to communicate effectively with this cohort. So I would definitely agree that, yeah, it is critical that we do this type of engagement.
Yeah, and I think Caroline has captured most of it. We are having a surge in HIV numbers within our teenagers, just because of that COVID period. And mainly behavior change is really difficult. And so if they're not in school, then they fall short of this. And so we have very robust HIV programs still operating within Kenya. And as Caroline mentioned, a lot of innovation around that, and a lot of co-creation with the youth being at the forefront of what they want and how they want it delivered. But I'll also say that when we look at perhaps the mental health space, for decades, maybe Africa and Kenya, we've been very behind in acknowledging, and this again is the data-driven agenda. We did not have numbers looking at mental health issues, and we had not prioritized it. And so now that we have that as a priority, I know there are robust efforts also ongoing. There are several platforms, mobile apps. I know there are platforms that exist that have even been run in our incubator system that then allow the youth to reach out to somebody for that counseling and also to determine the level that they need, the level of care that they need, and directs them aptly. So a lot of work is ongoing within the mental health space, as we've realized, even within organizations, within the workplace, that this is an issue that then needs to be addressed in various angles. And so cognizant of that, there's many technologies, there's many options that are now coming up. And I think Africa is open for things that are working and things that we can co-create that have worked elsewhere in the world. Thank you.
Thank you for that. I really think, on both issues, but particularly when we're talking about HIV that has been with us for decades, I think that it's really clear that without addressing the social determinants of health, you really can't, you can't cut, you can't cut the stemming of the flow of the virus at its roots without addressing social determinants of health. We see that with COVID, we continue to see this. So I think innovation and dedication to addressing those social determinants really is the only way to go forward. We have a question in the chat that I will read out. The African Continental Pre-trade Agreement was mentioned. Would you be able to elaborate on the best approaches to standardizing regulatory and legal frameworks for all countries, and what impact you envision this will have on using technologies across the continent? Ooh.
Big question. That's a big question. I don't know if I have the answer, but I have a answer. And what I would say is that many of these policies, standards that are there across countries were not put in place with innovation or technology or even a factor in mind. Each country dealt with its own issues as national issues. And that is why you see that if I'm an entrepreneur, I have built, let's say, a digital health platform, a telehealth platform. If I was starting off in Kenya, I would need to set up a brick and mortar clinic to be able to run a telehealth service. If I went to Senegal, I don't need to do that. So sometimes if I started from Senegal and thought that the rest of Africa is like Senegal, then innovation is unlikely to be successful. So what we are seeing entrepreneurs doing is, because most of the entrepreneurs who are building innovations for the health space are not necessarily health experts. And that is what we see across, the business. If you're looking at InsurTech, most of the InsurTech organizations are not people who are from an insurance background. So that's why we see organizations like Amref could play a critical role, because we work across 33 countries in Africa. We understand policies and regulations. We understand how to do business, how to do the business of health in many of these countries in Africa. So how do we, leverage each other's strengths to be able to build products and then to lobby for concessions from government? Because in many cases, we see that when we come to government with propositions that would drive better health in their countries, most governments are willing to listen. But in many cases, they don't know how much the difference in policies can affect innovation. And because most entrepreneurs, do not know how to navigate the health system is complex. It is so heavily regulated. It is looking at how do we, they have a duty of care to populations. It's about life and death. So for them, they are very protectionist. And how do we then ensure that we are providing the right information to de-risk the decisions that governments need to make around policy? So I don't think that there's a perfect answer yet. We are still working towards it, but we have seen successes in terms of changing policy, harmonizing certain policies to allow innovations to thrive.
Catherine, did you have anything to add on to that one big question?
I think Caroline has tackled it well. And even when we look at this regulatory issues and policies, something as basic as data costs vary from one country to another. I'm talking about internet and mobile telephony. And those varied ranges then also inhibit the rate at which we can innovate and use innovations, especially the ones that are internet-based. And so, yes, there's need to then see how we can regularize and standardize these things as it impedes on the work that we are doing and slows down the rate of impact. So, yeah.
Mm-hmm. And I guess that's why, Amref is in such a good position, because of the footprint we have across the continent, because of the close relationships we have with governments and regulatory bodies and different health systems within different countries. We're in a good position to be innovators, to be champions to push forward, and to keep doing the work that we're doing. Well, I'm not sure if there's one last question. We might have time for another one, that we are pretty much at the top of the hour, which has gone by so quickly. Can't believe it. Yeah, it's been such a great pleasure having you both with us, Caroline and Catherine. Your insights and your, this is part of what you live at Amref Health Innovations on a day-to-day basis. But it's certainly great for us as your colleagues in the larger Amref family to get a little insider, but it's definitely great for all our supporters and partners on the call to hear about the work and be inspired and, renew their connections with us. So for that, we're very grateful. We're also very grateful for accommodating the 8-hour time difference. And yeah, for your brilliant insights as always. So a big, huge, warm thank you very much from all of us. And yeah, just looking at the chat, I think there's just lots of thank yous. So thank you to you. Thank you to everyone who has taken an hour out of your days to join us. And yeah, we look forward to hosting more of these events and having more of these conversations and showing off and showcasing a little bit of who Amref is. Thank you.